Thanks, John. Thank you very, very much. Why don't we start for 1 second? Does somebody on the phone have a question? If you just push *7, and we'd be, tried our best to answer it, or any comments, please.
Hi, I have a question.
Please, go ahead.
Hi, this is Diana Elson calling from ICE. How are you?
Hey, how's everything going?
Hi, Diana.
Hi. So I really appreciate the discussion, and John Workington, thank you for including the discussion of corrections. So as many of you know, we have a nationwide population of detainees that are all foreign-born, and so I would assume that you would consider them all falling into a high-risk population. Detention facilities do have requirements to screen, either as part of ICE detention standards or state requirements. Our standards are usually to screen for TB disease. Local jails, we are hearing from local jails in all regions, and they are starving for guidance. So I'd encourage TB programs to please reach out to your local jails with guidance. They are coming to us for guidance. We're trying to get an interim solution approved, and it's probably as cumbersome as getting an order from the governor as well. Most ICE detention standards require a screening at intake, which is, exceeds the time frame for CDC guidelines. So I wanted to hear from all of you and see, what we suggest. We are proposing, allowing facilities, and these are mostly facilities that are not those that we staff that use digital radiography, but to allow screen with chest x-rays for TB disease, but of course that's going to be very costly. It will also increase the time frame. We'll run into issues of people being transferred possibly before the screening is accomplished. We do transfer people within the system across jurisdictional lines frequently. So this is a huge, huge burden for detention facilities, and please keep that in your awareness. Any suggestions that you can give for high-risk populations in detention facilities?
Yeah, this is Dave Ashke. I know in Florida, when we're now dealing with our jails, again, a little different than the detention, but one of the things that we are switching to is obviously we're still using a risk assessment and we're doing the questionnaires for active disease. But when it comes to infection, I mean, we are switching to IGRAs. And again, if you look at IGRAs, a lot of the problems occur if you're doing serial testing. I think that's where it gets a little more difficult. But for our cases where, in our congregate settings, in corrections right now, we are suggesting, because there's such a turnaround in our jails, the switch to IGRA. Of course, that has caused some issues as far as availability, and cost. But that is an option. For our prisons, again, we are, where you have people there for a long time and they're doing annual testing. We're just holding off unless there's some sort of a symptom. And then for new admits to our prisons, we are doing IGRAs up front, and then we plan on repeating, if the facility uses skin testing, is going back to skin testing once it becomes available. I'm not so sure if that helps or not, Diana.
Well, we discussed IGRAs, but a lot of local jails, they don't have the training, they don't have the CLIA-approved lab to do them. So for them to what they can implement themselves, I don't know. We're a little bit.
I agree. One of the things that's interesting, just as a kind of an aside, just a little, one of the things we're finding is that as we're looking more and more to IGRAs, and I see this on the chat, and just to make a comment, it's amazing how the prices that were being offered is really tremendously going down, to the point that It is getting, it is getting very close to the cost it would, for 2 steps and all the extra, I mean not for 2 steps, for skin testing and having 2 visits and all the extra quote-unquote x-rays that we think we do because of quote-unquote false positives. So I do agree with you that there is an issue with training and it takes time, but the big thing everybody always talks about is the cost. But we're seeing tremendous drops in cost beyond what we would ever, have thought. As a matter of fact, at least on our state contract now, we're being offered $25 for a particular test, which is really made us rethink about our, what testing we're doing. So I suspect, if the price was right, especially long term, then it would be worth your while to consider retraining staff.
Yeah, Diana, this is Sundari. I just wondered, what's the main obstacle with doing that in your facilities?
Well, no, it's not our facilities that we staff. It's the 250 local jails nationwide that we do not have direct oversight of the medical care. They do their own procurement. They probably don't get special pricing. We don't train them. They would be, they're under their own jurisdictional authority. And so, whatever they're dependent on whatever relationships they have with their local health departments for technical assistance. But they're coming to us because they're having trouble meeting standards.
Yeah, I think your suggestion that the local and state health departments on the line reach out to their jails and partner with them in trying to find the way forward is probably really important. I'm sure many of the programs already are, collaborating with their jails.
All right, thank you, Diane. Thank you very, very much. Do we have another question on the line, or else I can, I have a couple questions here. But,
yeah, hi, David, Mark Lobato.
Hey, Mark, thank you very much. I appreciate you, please, you've been very, very busy.
Yeah, I've been following the chats, and it's very interesting because I think the flavor of actually how this is impacting the programs is reflected in that. One theme that's been fairly prevalent is the regulations requiring either annual testing or either in healthcare facilities or corrections or long-term care facilities. So even though we recommend to defer some of this testing during the shortage, it may be very difficult for programs. So one of the nurses suggested that CDC and the RTMCCs perhaps host another talk more of the how to do and how are programs dealing with these regulations and how are they dealing switching over to IGRAs and the issues of different solutions of PPD tuberculin.
Mark, you worked that out perfectly. We planned it and practiced it well, but you're exactly right. Coming up relatively soon, we'll get out all the announcements, but I know from the SNTC's perspective, our next grand rounds will be exactly that, on practical issues in LTBI, specifically on the IGRA. In fact, we got a lot of questions specific to the IGRA that we thought would be beyond this webinar, but very, very important, and that will be coming real soon, and I totally agree with you, including, and we'll take you up. Matter of fact, I think you just volunteered yourself. But, it's very practical as far as guidances and regulations. So thank you very much, Mark.
All right, thank you, Dave.
One of the questions that was brought up on the chat was that, the question was Sanofi's recently announced 10-dose vial program available to private providers or to public health? And again, Sanofi does, they do apologize for not being able to join. They would have liked, they just had some conflicts. But they did send out a message to me for that the 10-dose vial is available to practitioners, or as they call them, end users, meaning either public providers or private providers who use it. And they just call the 1-800-VACCINE. One of the things they asked, of course, is that that there may be some interruption because of the demand. But we're already seeing on the chat that people are getting it, and I do want to clarify something I said before about the price. That was not through the company. The company's prices, from what I understand, are the same. They also said that they're hoping that the 50 dose vial will be out by the end of May. And as you also know, and we have Steve Richardson on the phone, if you have a question for JHP, who's very, very kind to join us, they also have an allocation program to get applesol and are there to, if you need it, to make it available through their system. So I just wanted to say that at least for the question, it is available to both private providers as well as public health, and I'm also being told that it is also being distributed to the wholesalers too, which was one of the questions. Was it only to the providers? So I hope that answered that question. Do we have another question on the phone? If we could go to a question on the phone. All right. Another question we had online is some universities require TSTs for nursing and medical programs. Do you think this should be limited? And I don't know if John wants to or Mark want to answer this, but the testing that we do in among healthcare workers is a little different because we serve a couple different programs. The reason we do it for a couple different reasons. One is that obviously if a healthcare worker should develop TB, it could be very catastrophic considering the significant number of immunosuppressed individuals that we deal with. So we want to know that if we're infected, that we would hopefully try to take the meds to prevent it. But the other thing is that frequently, if there is a case of TB, we need good baselines among our healthcare workers, and that's why it's important, as John pointed out, not switching back and forth and having good baselines. So I don't know if John or Mark want to, or Sanjay, you want to comment on limiting it in healthcare workers, but I'm not so sure necessarily that the move would be to limit it. I think it's more important that we base it on the risk assessment of the healthcare worker and the facilities they work in and base it on that. Do you guys agree?
Well, Dave, this is John, and I would just add that it really needs to be a local decision because the healthcare worker in Miami is not the same as the healthcare worker in Des Moines and is not the same healthcare worker as in San Francisco. So really, I think that should be a collaborative decision between the infection control practitioners that work in those institutions and the TB control authorities that serve those jurisdictions.
John, I totally agree. Thank you very, very much. I appreciate it. I guess, we got a number of questions, and I know, John, you addressed it, but we're still getting, the question switching between Tubasol and Applesol. And I guess just to clarify one more time, is just that, I think you'd agree that you're always better off, looking at apples and apples. It makes it easier to interpret, if I'm correct.
Well, it does, Dave. I think that if you just have patients coming through a clinic and one-time testing, that the impact of switching between the two antigens is probably not substantial. But if you have serial testing where the same person's getting tested over and over, switching between the two antigens probably does make a difference. So if your testing is, for example, in an immigration clinic where you don't anticipate that very many of the patients are going to get tested more than once, the switch between antigens should not make a substantial difference.
I agree. It's that serial, but I totally agree. All right. Do we have another question on the line?
And there is it's *7 to unmute your line.
Thank you, Sundri. So,
Hi, we have a question.
Please.
We were considering switching to the QuantiFERON Gold prior to this shortage on new hires, but then annually doing TB skin testing, basically due to the availability of the staff to do it. Is that a good option to do those two things?
Well, this is John speaking. I think it's an option, but if I were running a program, I would not want to go there because it's two different kinds of tests. And if you're using the QuantiFERON test or T-Spot, the other IGRA that's commercially available in the United States, and then you use a skin test later on, then you raise a number of issues. First of all, the concordance, the agreement between IGRAs and the skin test is only fair at best, and so you're going to get probably a different result more often than you'd like to see. And the other problem is that with that kind of a program, you're not allowing for the fact that once that person comes in for the third test, in other words, the second skin test, there could be some boosting, and you didn't have any two-step testing at the beginning to, diminish the effect of boosting.
Right.
So I think that it would be opening the door to a whole lot of unexpected problems.
Thank you.
You're welcome.
And where are you calling from?
North Carolina.
North Carolina, okay. All right.
And do we have another question on the line? Star 7 to unmute. Well, we had a question that was sent, we had a number of questions that was sent in, but a number in particular were about, discussing recommendations for screening of newly hired healthcare workers during the shortage. Sundri, do you want to discuss it, or would you like me? I mean, just as far as, what are different groups doing? I mean, as far as some are, I think, postponing it, while others, I think, are using like an IGRA, at least initially, and then once the skin tests are going back, once the antigens are available, would go back to their normal routines. Do you agree with that, or anything else?
Well, Dave, this is John. I think if you look at, for example, the recent MMWR publication, we've already listed what the options are from the federal perspective, and we made those options very broad to give leeway for the state and the city and county health authorities to make their own decisions, and those decisions would be based on, availability of testing methods, expenses, and the epidemiology of TB within that jurisdiction. Otherwise, we can't comment much further on what's recommended from the national level. Also, we don't have a survey method immediately at our fingertips to tell us what are people doing, so I think it would be more informative, to start with what we've heard from John Workington and Dick Brostrom and Margaret Oxtoby. That was a sample of 3, but I bet there's a different approach everywhere.
I totally agree. Thank you very, very much. Another question we're getting in, just, again, we're not going to use too much on IGRAs, but, the question always comes down, what about children less than 5, especially with the limited data from IGRAs? Is skin testing still like the gold, the most recommended standard for children less than 5? And I think we'd agree, given the limited data, that the answer is probably yes.
Yeah,
Sundri
Phil,
or John?
Phil is going to speak to that.
Hey, Dave.
Hey.
The recommendation, still stands that skin test is preferred in children less than 5 just because there are a lot more data. But it is clear that IGRAs are an acceptable alternative, and clearly if you don't have the option of a skin test, IGRAs are acceptable.
Exactly right. I think it's, we have a lot more data for obviously individuals, over the age of 5, and there's still the Red Book still talks about children under the age of 2 that the IGRA not be used. But I think again, it's one of those, if you have no other choice, you just use it. But I think you'd agree with limited, understanding that there's limited data. All right. Do we have another question on the line for?
I have a question, please.
Please go ahead.
Oh, this is Melissa from Kentucky.
Hey,
Quick
Melissa, how
question:
you doing?
if a facility switches to using the IGRA testing for employees, that of course you would do that one time, and that would alleviate the need for initial 2-step. Is that correct?
That is correct, because skin testing can cause a boost because you're introducing an antigen into the skin, and it can stimulate the delayed T-cell hypersensitivity to react more strongly the next time there's a skin test. But when you do an IGRA, you're not introducing an antigen into the patient, you're just collecting some blood. So that's why the 2-step testing is not part of serial infection control programs with IGRAs.
Okay, thank you.
You're welcome.
Great. And we're being asked on the online, I have a question here to address the serial testing of healthcare workers when switching to initial IGRAs, annual IGRAs, or annual risk assessments. And I'm not so sure how much we really want to go into, because I think this is a whole other webinar, especially with some of the more recent articles and studies looking at serial testing in healthcare workers, especially overseas and in the United States. Other than to say that, and I would turn it over to you guys, but I think the issue comes down to that we're still learning on that, and I think it's something that we will probably be discussing in much more detail with the next webinar, unless John or Sundri, you want to comment a little more on that.
Yep. Dave?
Yeah, please.
This is John. I'll interject with a little observation about producing skin test antigen. Even though the question hasn't come up, we discussed it on Friday, like, why don't we just make more skin test antigen? And the short answer is not that simple, because the antigen is very difficult to produce and the standardization process is detailed and precise. About a decade ago, I surveyed the two manufacturers of tuberculin solution, and I was able to estimate that allowing for 10% wastage, we give about 18 million skin tests per year in the United States. And even though TB cases have decreased, the policies and regulations that affect all that skin testing haven't changed that much. So I'd be willing to bet that we're still probably at, at least 15 million skin tests per year in the United States. That's a whole lot of skin testing, and probably most of it doesn't have a lot of public health impact. But back to the production of tuberculin skin test antigen, we would love it if the producer of Aplasol could just snap fingers and instantly turn out a few thousand more vials of their antigen, but that can't be done. Also, the question comes up, well, why don't we just import something different? And I'm not going to wish that on anybody, because around the world, quite a few different skin test antigens are manufactured, and they're standardized in their own countries according to their own standards. But if we were to get one of those approved in the United States, the approval process itself would be very long. I'm sure that it would take more than a year, although I don't know all the requirements. And if we did get another product into the United States, even if it met specifications, which would be very difficult to do, it would still behave as a third product. It could not be identical to Tubrsol, and it could not be identical to Aplasol, just in the same way that Tubrsol and Aplasol, even though they give comparable results on a population basis, they do behave differently if you go patient by patient. So that's just, some questions that hadn't been raised so far.
John, I really thank you very much. I mean, because I think, there was that issue that people felt like, I don't understand, why can't we make more, why don't we import it? I think it's so important. That's where, like, skin testing antigens, it's so funny, I was saying this the other day, that we really have had, in recent years, almost an inundation of how IGRAs work and the whole, and how they're produced. Whereas with skin test antigens, which we've had around for over 100 years, actually, I can't remember really the last in-depth, discussion on the difficulties with it. And I think that's brought a lot of this to light, and how vulnerable we are if something goes wrong, and actually how lucky we've been that there hasn't been more going wrong, and what the process are to standardize. So, John, I appreciated your discussion very, very much. One of the questions we're being asked is what is the current date predicted for the resolution of the shortage? And, as you guys know, and has already been stated, it's been kind of going back and forth. We were first told that late April and May. When I spoke to Sanofi, at least, my understanding was that they were hoping to have right now they're having the 10-dose vial out, and they're hoping to have the 50-dose vial out relatively shortly. But even when that comes out, I think you'd agree there's a lot of back order issues, and it may be a little while. But they're, in relative terms, it seems like they're at least discussing that they're hoping it will be relatively quickly.